NCUIH, the Technical Assistance and Research Center. I'm pleased so many of you were able to join us. We have a really well-stacked agenda for everyone. As a matter of fact, if we were all sitting on my couch, we'd be violating the social distancing policies. We're looking forward to having a really full agenda today. Several guests have joined in, and I think we have pretty much everyone here. So just want to begin to go through our introductions and get to our conversation as quickly as possible. We're going to try and stay as informal as we can. We have a fairly large audience, so we'll, of course, be asking those folks with questions and comments to either raise their hand or enter their question in the chat box, and we'll go through those directions as we get to time for Q&A. You can see quickly how you're directed to add questions. We have both the question chat box as well as the feature for raising your hand. Again, as the time comes, we will go through those directions as well. I wanted to offer a quick reminder while we have our attention that we're going to try to have an ongoing series of communities of learning. And the next date that we planned 2 weeks from today is April 17th. At that time, we'll be discussing the COVID-19 response, of course, but we'll be looking at self-care and how to help with the human resources that are involved at your UIO and at other agencies, so that we'll be sharing resources as well as tips and ideas about how to take care of the mental health needs, emotional supports, and so forth that are so important at this point in time in the midst of this pandemic.
Mark, I'm sorry to interrupt, but if you wouldn't mind speaking a little bit louder, it seems that folks are having a little hard time of hearing. I would also recommend, if you're able to call in using a phone line, the phone conference line is listed in the notes pod. That also may clear up some of the technical difficulties you're having through the actual laptop.
Okay, I hope that the volume a little better on the audio now. I'm hoping you can hear me okay.
Is that better for folks, or is the echo going? If not, we may try muting some of the lines, and that may be the issue as well. It has not helped. Okay. If you just stand by one moment, I am going to mute all of the lines until we get to the point where you might be able to speak at that point. For 1 second.
Sorry for the technical difficulty.
Your conference is being recorded.
NCUIH is a national membership nonprofit organization devoted to the support and development of quality, accessible, and culturally competent healthcare services for American Indians and Alaska Natives living in urban settings. Today's presenters represent both the NCUIH staff as well as the staff of our guest UIO. Julia Driver is the Director of Relations, and she'll begin. Sonya Tenowski, Angelina Speltz, Victoria Anderson, and Anu Balkarashnan are the guest presenters from the Santa Clara UIO. So without further ado, we'll begin the presentation, and I'm going to ask Julia if you would like control of the slides. It's your time now.
Thank you so much, Mark, and yes, that's totally fine. Thank you. Hi, everyone. Thank you so much for joining us. My name is Julia Dreyer. I'm the Director of Federal Relations here at NCUIH, and I'm going to go over some of the policy updates briefly before we get into some more
The leader has muted your line. To unmute your line, press star 6.
Julie, are you still with us?
Hi, can folks hear me? Can
Yes,
folks
we
hear
can.
me?
Thank you. Yes, we can. Yes, we can hear you, Julie. Are you still there?
Hey everyone, I'm so sorry about that. I just got disconnected, but I'm back here now, and we'll start going over some of the policy updates related to COVID-19. So this first slide has, it looks like some more formatting is off on Adobe. I apologize for that. But just going over the beginning of the timeline for COVID-19. On January 17th, the first CDC briefing on the 2019 novel coronavirus happened. On the 21st, the first U.S. case was confirmed in Washington State. And on January 29th, the White House announced the White House Coronavirus Task Force. On January 30th, the World Health Organization declared a global health emergency. On January 31st, HHS Secretary Azar declared a public health emergency. Then moving forward to February, on the 24th, the White House sent a letter to Congress requesting $2.5 billion in supplemental funds for coronavirus response. And then February 26th, CDC announced its the first case of community spread in the U.S. in California. Oh goodness. Sorry, this one is cut off on Adobe. I apologize. But continuing through the timeline, on February 28th, Nikki sent a letter to Appropriations Chairman McCollum asking for ULL emergency funding. We will be sure to send out these slides with the updated format and so they're easier to review. On March 4th, Congress announced $8.3 billion in coronavirus emergency funding. And this legislation included a minimum of $40 million for tribes, tribal organizations, and urban Indian organizations. On March 6th, President Trump signed the Coronavirus Preparedness and Response Supplemental Appropriations Act, which was the first coronavirus package that Congress passed and enacted. And on March 10th, Missouri sent a letter to Secretary Azar asking for $120 million instead of the minimum $40 million set aside of the CDC funds to be provided to Indian healthcare providers. On March 13th, President Trump declared a national emergency. And on March 14th, Missouri sent a joint letter with other national Native organizations to appropriations committees outlining the needs of Indian country during this crisis. Continuing through the timeline, on March 17th, Senators Warren and Udall introduced the Indian Country Access to National Stockpile legislation. And on March 17th, Missouri sent a joint letter with the National Native Organizations to Representatives Pelosi and McCarthy. Also on March 17th, Missouri sent a letter to the Native American Caucus asking for emergency funding for ULLs, parity in Medicaid FMAP, and medical malpractice liability coverage. On March 18th, the second coronavirus package passed through Congress, which included $64 million in funding for IHS. Sorry, it sounds like it's a little hard to hear me. Hang on one second. Okay, is this a little bit better? So continuing forward, the March 18th second coronavirus package that passed through Congress includes $64 million in funding for IHS. Apologies for that, everyone. I know that all of the conference lines have been really overloaded over the past couple of weeks, so hopefully this is a little bit better to hear me, though. Just continuing on, President Trump also signed the second coronavirus package on March 18th, which is the Families First Coronavirus Response Act. On March 20th, NCUIH sent a joint letter with the national Native organizations to both Senate and House leadership on COVID-19 stimulus package priorities for Indian country. And also, on March 20th, CDC announced its decision to disperse $80 million in first-round coronavirus funding to Indian country. On March 25th, IHS held Urban Confer on second-round coronavirus funding. And on March 26th, Congress passed the $2 trillion stimulus package that included $1.032 billion in funding for IHS. This was the third coronavirus package, which was also signed by President Trump on March 27th. Also on March 27th, NCUIH sent a letter to IHS regarding the dissemination of emergency funds to UIOs. On April 1st, IHS held Urban Confer on third-round coronavirus funding. And just recently today, April 3rd, IHS announced its decision to disseminate those funds. This slide provides a summary of some of the advocacy that NCUIH has been doing. As I mentioned in several of the items prior, we've been working with other national Native organizations in a coalition of requests to Congress to include key priorities for Indian country. Of this, one of the appropriations requests was for $1.2 billion in funding for the IHS services account. This includes $94 million for UIOs and emergency funds from the services account. We've also been pushing for 100% FMAP parity. And the 100% federal medical assistance percentage rate was included in initial drafts for Phase 3 coronavirus legislation, and was also included in the House bill, but it unfortunately did not make it to the final CARES Act. So we will continue to push for it to be included in Phase 4. In addition to this, we also have been pushing for other Medicaid priorities, like the four-wall fix, which would enable billing for Medicaid services that are provided by Indian healthcare providers outside of the four walls of the facility. In addition, we've been pushing for national stockpile access, and there are two bills in Congress that would provide for this. It's H.R. 6352 and S. 3514. In addition, we've been pushing for FTCA parity in medical malpractice coverage for UIOs. This slide represents the Phase 1 coronavirus package. So this was originally H.R. 6074, and it's the Coronavirus Preparedness and Response Supplemental Appropriations Act. This act appropriated funds to CDC with a minimum of $40 million that was required to go to Indian healthcare providers. CDC announced its decision that it would disseminate these funds in two parts and actually increase the minimum set aside to an $80 million total dissemination to Indian healthcare providers. So Part 1 included $30 million to tribes and tribal organizations and $10 million to tribal public health capacity building cooperative agreements with NIHB and NCUIH. This included $2 million to NIHB and $8 million to NCUIH.
I think we may have lost Julia. If you could just hold on just one moment, please. Thank you.
Oh, I'm sorry, can folks still hear me?
Yes, we can hear you now.
Oh, okay, great. Apologies for that. I'm not sure what happened. Also included in the first coronavirus package were some appropriations for the HHS Public Health and Social Services Emergency Fund. And of this, HHS directed $70 million in funds to go to IHS. And IHS announced on March 27th the following dissemination. $30 million of this to go to IHS federal health programs and $40 million to purchase personal protective equipment and medical supplies through the National Supply Service Center, which will be available to ITU facilities. Phase 2 coronavirus legislation was the Family's First Coronavirus Response Act, and this appropriated $64 million to IHS. And IHS's decision for this fund
Your mic is gone out again. Is everyone able to hear my voice?
I can hear you.
Okay. Julian, can you get my phone? I'll try to hear although I am hearing that echo. So
I hear the echo as well.
Mark, if you can mute your mic. Okay, I think we're good now. Okay, so just recently, IHS actually released a Dear Urban Leader letter that actually stated the appropriation of $64 million for IHS, and that decision included $3 million for UIOs, as well as $61 million to IHS federal health programs and tribal health programs through the ISTIA agreement.
Hi, everyone. I'm sorry. Can you hear me again?
Yes.
Okay, wonderful. I'm so sorry. I'm not sure. I think that the conference lines are just really overloaded. We've experienced issues with other calls had over the last couple of weeks, and I really apologize for the technical difficulties. So hopefully it will continue to work for me to get through this presentation. And thank you so much, Dr. Fowler, for assisting with this. So the Phase 3 coronavirus package, which is the CARES Act, I believe, Dr. Fowler, had you just started on this slide?
Yes.
Okay, wonderful. So this appropriated funds. Wonderful, thank you. This appropriated funds to CDC with a minimum of $125 million set aside for tribes, tribal organizations, and urban Indian organizations. In total, it appropriated $1.032 billion in funds to IHS, and a minimum of $450 million of that must go to IHS directly operated programs, tribal health facilities, and UIOs. $65 million for electronic health record stabilization, and all remaining funds will be allocated at the discretion of the director to be used for IHS service line items, and also up to $125 million can be transferred to the IHS facilities fund. This package also appropriated funds to SAMHSA with a minimum of $15 million for tribes, tribal organizations, and urban Indian organizations. Oh, I think that I'm missing a slide here. I apologize. Also in the third package is some appropriated funds to HRSA, Rural Health, which had a minimum of $15 million for tribes, tribal organizations, and urban Indian organizations for the Rural Health and Telehealth Network programs as outlined in the CARES Act. It also reauthorizes SDPI at current funding levels through November 30th, 2020. And the IHS dissemination of funds under Phase 3 was just announced about just over an hour ago. and includes $30 million in funding for UIOs, and that is available on IHS's website under the newsroom and the Dear Urban Indian Organization Leader Letters, or the Dear Tribal Leader Letters. This last slide shows some of the news articles that have been covering urban Indian organizations and NCUI's efforts to get funding to UIOs and other support during this pandemic. So you can see some articles from the National Journal, The Guardian, Politico, The Hill, and NPR on this slide. Thank you so much. I, again, apologize for the technical difficulties that we've been having during this call. We will certainly plan to circulate slides, and please feel free to reach out if you have any questions or comments on these slides or any of the policy updates.
Since we've experienced a few delays, maybe we'll have a shortened Q&A. And Julia, if you'll be able to hold on to the end, maybe any questions that arise, you can address at that time. So I'd like to move on to our next presenter. This portion of our session today is about the COVID-19 testing and the drive-through procedures. So I'm going to turn over control now to our presenters from Santa Clara. Angelina or Sonya, will you be taking control of the slide set, or would you prefer we advance the slides for you?
You can advance the slides for us.
Okay. You
can everyone hear me okay?
I hear
okay.
you fine.
All right, so thank you, everyone. My name is Angelina Speltz, and I'm the Director of Clinical Services at Indian Health Center of Santa Clara Valley. We also have Victoria Anderson, our LVN, and Dr. Balakrishnan, she's our CMO, and Sonya Tenowski, our CEO, that's on the line. So we're going to be talking about our drive-through testing procedures today. Just to give you a quick background on IHC, we're located in San Jose. We serve about 22,000 patients per year. We have 4 medical sites, 2 dental sites, WIC services and integrated behavioral health services, as well as community wellness and intertribal resources for our community. We are located in Santa Clara County. Currently in Santa Clara County, we have 1,019 cases of COVID. We've been testing at our clinic since March 11th, and we've been doing the drive-through testing. So first we're going to talk about setting up and preparing for the drive-through testing. Can you do the next slide, please? So the first thing that we want to do is determine where are we going to perform the testing. Some things that are helpful to consider is parking. Is there ample parking? Is the parking lot close to the clinic? You want it to be close to the clinic so that way there's easy access to bring the specimen in right after each test. And also, is the clinic that you're doing the testing at, does it have adequate storage for the freezers or refrigerators for the specimen? At Indian Health Center, we have 4 clinic sites, so we decided to consolidate all of the testing for our different sites' patients to be just at 2 of our sites. So our Meridian Clinic, which is our largest clinic, all of the patients that are patients of the clinics that are contracted with Quest Labs have their tests done there. We have our pediatric center where those patients that are contracted with BioReference, all of the testing is done at that site. So the reason why we wanted to limit the sites is because we want to limit the exposure that potentially that patients that potentially have COVID have with our clinic staff and also with other patients. And it also helps us keep track of our test kits, our results, and our PPE that we need to safely perform these tests. Are you guys hearing an echo on me? No? Okay. So, no? Okay, good.
There's no echo.
All right, so next we're going to talk about the handling and the storage of the specimen and obtaining test kits. So our county is recommending that we use nasopharyngeal swabs as opposed to the oral pharyngeal swabs. In Santa Clara County, there's actually a shortage of test kits. So our Director of Population Health has been working really closely with Quest Labs to be able to get the shipments. These test kits are important because it's helping us determine how many tests we're going to be doing per day and also who we're testing based off of that inventory. Another trick that we've been doing to obtain test kits is having each of our sites order the maximum number of test kits, which is only 5 per day, so that way we can keep getting the test kits to come in. Sometimes the orders get canceled, sometimes they don't, so we've just been trying every day to get these kits. You also have to consider the storage of the specimen. So Quest Labs is requesting that we store our specimen in a freezer. So we actually had to buy a new freezer because we only wanted the COVID test specimen to be in that freezer. So if you're considering doing testing, get your freezer quickly because like many other things like toilet paper, they are going quickly. We actually bought the last freezer at Best Buy. Just work with your lab to see what the storage requirements are and then also arrange the pickups for the specimen. So Quest comes out and picks up our specimen daily. So scheduling the tests, first you want to determine what your testing capacity is. We determined our testing capacity based off of our patient volume, our staff capacity, how much PPE we have, and how many test kits we have. We use our electronic health record to schedule the appointments, and our appointment guidelines are 30-minute appointments, no double booking. We have 10 slots per day, and we also limit it so that only the nurses can book the appointments. That way we're ensuring that the staff are following the guidelines. Next slide, please. So for billing, our labs cost $62. We're billing patients' insurance. If a patient is uninsured, we are not billing them. Just to make sure that the patient doesn't inadvertently get a bill, we send our billing team a report of the uninsured patients that are getting the test, so that way they know not to send the patient a bill. For the lab orders, we're using the following ICD-10 codes, J06.9, acute respiratory infection unspecified, and if a patient does have exposure, had exposure to a patient with known COVID, we're using Z20.828. Next slide, please. So staff performing the test. So we're having our nurses collect the specimen, and then we're having the MAs assist in holding the cooler and helping the nurse get the specimen into the bags. We definitely want to limit the staff that are doing these tests, so that way we're limiting the number of staff that are potentially being exposed to COVID-19. So we only have 1 or 2 nurses per testing site that are doing the test and 1 or 2 MAs. So in addition to limiting the staff that are being exposed to COVID, if your organization or your county is instructing you to reuse PPE like N95, this is also beneficial because it limits the amount of PPE that's being used. In order to prepare our staff, can we go back, please? Thank you. In order to prepare our staff, we had Quest Labs come in and do a refresher with our nurses on collecting the nasopharyngeal specimen. Our HR department arranged to have N95 fit testing and medical evaluations for all of our staff. We had an outside vendor come in and do that. It was a really easy process for our staff. They worked with groups of about maybe 7 to 10 people at 30 minutes at a time in our break rooms to do the fit test. And then we also had a refresher on donning and doffing PPE. We used the CDC as our resource, and we also showed YouTube videos. YouTube is our friend. And then back when we were able to meet as groups, we did a refresher at our medical department meeting on how to properly put on N95s, gowns, gloves, face shields. So we just it was good to have a refresher on that. Next slide, please. Okay, so next, it's time to test. So we developed an algorithm for testing. I think it's really helpful for the providers and the nurses because we get a lot of requests of patients wanting COVID tests. We get voicemails of patients saying, hi, I'm calling because I want a COVID test. So it's helpful to have this sort of algorithm to determine what's appropriate and what's not. We've made 2 adjustments to our algorithm so far, and we just make those adjustments based off of the number of test kits that we have and how many days of testing we have left based off of our current inventory, our supply of PPE, and then also what the CDC or our county public health department is recommending. Next slide, please. So this was our first phase of the algorithm. Basically what we did was we defined what the symptoms are for COVID, and then we defined what we consider a high-risk patient to be. And then we broke it down with the various situations that we've been seeing. So we looked at patients that had known exposures and whether they had symptoms or not, no known exposures, and with that if they had symptoms or not, and then possible exposures, so if a patient works in a healthcare setting and whether or not they had symptoms or no symptoms. And so based off of the patient's risk factors, we determined whether we wanted to test them, not test them, or test them if tests were available. And we prioritized all of those different categories. This was when we were first starting the testing, and we didn't have a lot of test kits. We didn't know when more were coming. But when we did get more test kits and we had a better idea of what the access was to testing, we expanded our testing criteria. So if you can go to the next slide. So this was our phase 2. This is our current algorithm. So now we definitely expanded the criteria so that way more patients are able to get the test. Definitely, we communicate with, we have weekly calls. Our public health department hosts weekly calls, and so we've been sitting on those calls just to see if they're offering any specific guidance. So for example, Santa Clara County is not recommending tests of cure just because they're trying to save the test kits. So if your county public health department is having those types of calls, it's really helpful because that could help determine what your algorithm is for testing. So now I'm going to pass it over to Victoria. Victoria is our back office supervisor at our Meridian site and also an LVN. I have to give a hats off to Victoria because in addition to supervising all of our MAs, she's been performing all of the COVID tests. So she's going to talk about that process. Everyone. So for ordering COVID tests, that all starts when a patient will go ahead and call into our office, and they go ahead and let either our operators know that they're feeling sick or if they've been exposed. Recently, we have had an increase of new patients calling in to get tested. So once we get those calls, they are transferred over to a triage inbox that our nurses all work from. And our nurses will go ahead and pull from that and call the patients and get a more detailed history from the patient. So they'll want to know who or how they were exposed, what symptoms they're having, how long those symptoms have been going on for, and then we'll go ahead and give them emergency room precautions or urgent care precautions. We'll go ahead and also give them instructions on how to care for themselves while they're home. And then we'll let them know that we will go ahead and discuss everything with their patient or with their providers. And we just tell them to wait by their phone for a call. And then once we get all the information from them, we'll go ahead and forward that message to their PCP to determine if that patient should get tested or not. And then once the provider does determine that, they'll go ahead and send a message back to the nurse for scheduling or to give them more home care instructions if they think that the patient doesn't need to be tested. And then once we do get those messages back from our providers, the nurse will go ahead and call the patient and put them into a schedule. Can you go to the next slide, please? So we'll go ahead and put them into a schedule, and then we will give them instructions that they need to stay in their car until they are approached by a nurse. And then we'll also give them our cell phone number for our nurse line to call once they arrive to the clinic. And then we also do let them know that there will be a wait time because the nurses do need to put on their PPE. They need to make sure the tests are ordered and verify everything is correct on the patient's test kit. And then we'll also go ahead and remind them of their ED precautions, urgent care precautions, and their home care instructions until their test comes back. And then also, once the patient is scheduled, we go ahead and set up a global alert that is placed on their chart to just alert staff that, the patient does have a test pending and not to bring them into the clinic so that we don't, expose staff and patients if they are positive. For patient testing, once the patient arrives to the clinic, they are going to call the nurse line. There are times where, next slide. There are times when the patient does lose the number or they forget it at home, so they'll go ahead and call the clinic. There have been a few times where they do walk to the door of the clinic to let the screeners know that they are here for testing. So it's a good idea to make sure that the screeners are in PPE and have like a surgical mask with a face shield on just in case that does happen. And then when the patient does call, the screener goes ahead and informs them again to stay in their car and wait for the nurse to approach and just to be patient. Once we do order the test, once the patient is here, the nurse goes ahead and orders the test, and they print out the order and the insurance if the patient has insurance, and we verify the patient label, the insurance, and the order acquisition. And then there are times where I will have the MA just double check as a second set of eyes that everything belongs to that patient. And then the nurse and the MA, we will go ahead and gown up. We do put on, our gown, gloves, a hair bouffant, a face shield, and an N95. When we do approach the car to test the patient, the nurse will go ahead and speak to the patient while the MA waits behind the vehicle or in front of the vehicle for the sample. And then next slide, please. So for the testing part, I will go ahead and let the patient know that the test is very uncomfortable and that it will make their eyes water, it'll make them want to sneeze, and a natural response is for them to pull away. So I just ask that they try to stay as still as possible, and what helps is if they put their head between the headrest and the car door. That way they, can't move their head. And if they think that they will try to push my hand away, I have them sit on their hands just, to make the process easier. After the collection is done, I will go ahead and put the swab into the solution and hand it off to the MA, who zips up the bag and takes it inside. And then I go ahead and make sure that the patients have handouts that lets them know what to do while they're waiting for their test, what to do if their test is confirmed. And we also give them resource guides for the sheltering in place and also a resource on how to de-isolate themselves. Next slide, please. So this is one of the resource sheets that was created, or that was put together by our health educators. That lets them know where they can go and get food, the number they can call, and just gives them a little bit of information. Next slide, please. And this is another resource that we give them if they, in the packet of papers, it's what to do if you have a confirmed case, and we got that from the public health department. And we just let the patient know to read through those once they do get home. And then we have them both in English and Spanish, and just in case. And then next slide. And then there are the links for the educational materials. Next slide, please. So once the testing is done, the MA and we will go ahead and walk to our biohazard bin. And for the nurses, we go ahead and we doff all of our PPE. But the MA will only doff his gown and gloves because he still needs to bring the container into the clinic to put into the fridge. So once he does that, he will come back out and, once he takes off his contaminated gown and gloves, he'll go ahead and don a new pair of gloves and take the specimen back and take the specimen into the clinic, into the designated freezer, and then he will come out, wipe down the cooler, and then doff the rest of his PPE, and then we make sure we go and wash our hands before coming back or going back to our workstations. Next. So now I'll go ahead and hand the phone back to Angel. Okay, so next we wait for the results. So we started testing on March 11th, and initially it was taking quite some time to get the results, about 7 to 10 days. Now we're seeing the results come in a lot faster, between 2 to 6 days. Today, for example, we just got some results from the test that we performed on Tuesday, which is really great. Next slide, please. Can we do the next one? Thank you. So every day we track the tests that are being performed. So we do this in order to keep an inventory of the test kits. So at the bottom of the slide, you'll see the headers that we use. So we have the date that the specimen was collected, the total number of tests, and then as we get the results in, we update the positive and negative results, and then while we're waiting for the results, we keep that the total number of tests and the pending number. Our Director of Population Health also created a report using our patient population management tool, Relevant. It's our version of I2I or iCare. We create a report to run lists of patients that have had the test ordered, and that list displays the patient's information, their results, their risk factors, their insurance type, and so we use these reports to send over to our billing team to let the billing team know which uninsured patients were getting the test. Next slide, please. So for pending results, if it's been over a week and the patient hasn't gotten the results yet, we'll have the nurse contact the patient to just let them know we're still waiting for the results and please, please continue to isolate. Next slide, please. So for negative results, so the result comes into the ordering provider. Right now, we only have our Meridian site medical director ordering all the tests just because we want the results coming into one person, so that way if we do have a positive, we're able to act on it right away. And it also helps us just keep track of the test results and in order to update the global alerts in our test tracker. So the ordering provider will notify the PCP, and then the PCP notifies the patient, and then we remove the global alert from the patient's chart, and we update our test tracker. Next slide, please. So for positive results, this process is obviously a little more complicated. So the results come into the ordering provider. The ordering provider notifies the PCP, and then the PCP or the nurse notifies the patient. We then fill out our county's version of a confidential morbidity report. Our county calls it the Santa Clara County COVID-19 confirmed case report, and we email it over to them. We actually can't fax right now to our county because our county's fax machine is inundated. So it's important to check in with your county to see how they want these types of reports because they may have different forms or requirements. Also with Santa Clara County, we've been instructed that if the patient is homeless or lives in a care home or some other congregate setting, that we need to call them because the county is wanting to act on these cases really quickly. And there's also special resources for those populations. In our county, Santa Clara County, they're not contacting patients unless they're homeless or living in a congregate setting, because we've had so many community spread cases that we are needing to collect information on the patients and who they may have exposed to COVID. So when the patient does test positive, if their symptoms are mild to moderate, we're giving them ED instructions and just telling them telling the patient and their close contacts to isolate. So when a patient does test positive for COVID, we do keep the global alert on the patient's chart. That's because we don't want to put their diagnosis in the global alert, but we do still want staff to know that the patient shouldn't be coming into the clinic. We update our test tracker, and then we also check the patient's encounters to make sure that they haven't been in the clinic or had any exposure to our staff within the last 14 days. And this is staff that were not wearing PPE. So if there is an instance where a patient has exposed a staff member, our county is instructing us to have the staff wear a surgical mask for 14 days since the date of exposure and also be monitored closely for symptoms. So we're doing temperature screenings twice per day, and then the employee should also just self-monitor, and if they're having any symptoms, they'll need to stay home and also contact their provider. Next slide, please. So when the PCP notifies the patient of the result, they give home care instructions, isolation instructions, and then ED precautions. Some of the self-care information that they give is hand washing and taking Tylenol as a supportive measure. And then for the ED precautions, we're instructing patients to go to the ED if they're having chest pain, shortness of breath, or a fever higher than 100.4. Again, I think it's really important to work with your local public health departments because there might be resources for patients if they do have COVID. For example, in Santa Clara County, our homeless patients are being put in hotels in order to isolate. Finally, after the PCP notifies the patient of their results, the patient information is sent to our nurses, and then the nurses are following up with the patients periodically just to check in on their symptoms. Once a patient is asymptomatic, they're given the de-isolation procedures. So our county is giving us specific instructions for patients to de-isolate 14 days after a symptom onset or 7 days after they're asymptomatic, whichever is longer. So these instructions are a little different than what the CDC is recommending, so your county may also have specific instructions. Next slide, please. Finally, we did create a spreadsheet, so that way we can track the patients that have COVID and their follow-up care. So we check the patient's chart every day just to make sure that the patient's being followed up with, and we're also using this as a means to collect different data points like the date that we collected, the specimen, the date of the result, the patient's risk factors, their symptoms, their exposure source, their de-isolation date, and we also use this to track if the patient had exposed staff and then how long the staff should be wearing a surgical mask and which staff were exposed. And that's all we have. Are there any questions?
Hello, this is Mark Clark. I'm noticing that some questions have been answered in the chat box, so some of you may have already had your questions addressed. But it's a good time for anyone with regard to questions about the drive-through procedure, COVID testing, or even policy to go ahead and chat or enter your question in the chat box, or we can unmute your phone if you'd like to speak. But you'll need to raise your hand if you want to speak. At least one audience member has asked for copies of this tracking spreadsheet. That's noteworthy. Probably others may be interested in copies as well. I'd like to also alert you that the links for some of the downloadable contacts are shown in the web links pod at the top of our screen. And you can see it's called under the label web links 2. You can download the URLs for those forms that you'd like. Just a reminder, the full PowerPoint presentation is available under the full slide deck label on the chat pod, which says COVID-19 Drive-Thru test. You could download that as a PDF. Again, we're open for questions and answers.
Mark, it looks like we have a couple of questions that have come through. One is asking, do you use ECW? And they would love to have those protocols if they are available. It's either ECW or CCW. I'm unclear on that.
Yeah, we do use.
I think we
Would
lost
you be able
the
to provide
audio.
those?
We do use ECW.
And would you be open to providing those protocols for that?
So a lot of these workflows and protocols for testing, we had to write it up ourselves. So none of these were created in ECW, but and all the tracking that we have been doing is all manual. And we have just created a schedule in ECW just for testing purposes alone and ordering the labs. So other than that, we haven't really, the tracking has been manual, and like I said, like the workflow, is completely separate.
There's a question that's been in the chat pod as follows. Does your program offer pulse ox or thermometers to high-risk patients who are suspected to have contracted COVID?
Are you asking if we give it to them, or?
I'm just reading what was typed in the chat pod.
Yeah, no, we don't. We don't give them a pulse ox. We just tell them if they feel short of breath, when the nurses follow up with them, we do give them ER precautions when they come for testing, as well as when the nurses follow up with them. That's one of the questions that we ask, whether they're feeling short of breath, and we just tell them to go to the ER if they don't feel good. Most of the follow-ups that the patients complain of, the symptoms have predominantly been like fever, body aches, headache. Not so much shortness of breath, but the nurses have been instructed and the doctors have been instructed if anybody complains of shortness of breath, that's the time when they have to go to the emergency room.
Thank you. Next question in the chat pod is, what is the time frame that the global alert stays on the patient's chart when they test positive?
So we're keeping alert.
I'm sorry, say again. Currently, we don't have audio.
Can you hear me?
Not just
Hello?
let you now.
Okay.
Hello?
So currently, can you hear me?
Yes, now we can.
Okay, so our procedures for the global alert, so the global alert will stay on the patient's chart for as long as they need to isolate. So that's why we're tracking their de-isolation date. So our county is telling us 14 days after the patient starts feeling symptoms, or 7 days once the patient is asymptomatic, whichever is longer. So we're finding that it's 7 days after the patient is asymptomatic is longer. And so that's when the global alert would come off.
Thank you.
The main purpose of the alert is because some of the patients go to other departments within the agency for services, and we don't want any positive patient going to any other department and exposing anybody. Also, it serves as a way for us, another check and balance, to make sure that these patients are being closely followed in case somebody takes a turn for the worse and we need to send them to the hospital.
Thank you. Trying to capture the questions as they're entered into the chat pod. And we're right at 1:59. Our discussion today was scheduled to go to 2 p.m. We'll continue as long as we can. We're able to continue, and there's a question from Savia. When the patients are instructed to go to the ER and they don't have insurance, is it being covered by IHS?
No, that would be covered by the patient's insurance, and if they're uninsured, then I'm not quite sure.
So our county hospital has a lot of different programs that patients can qualify for. There's something called ability to pay. Depending on the income bracket and the immigration status, they can apply for an ability to pay program. And I know that patients have been able to qualify for Covered California and things like that, especially during this COVID era. So far we haven't had any issues with any patients receiving a bill or any complaints saying that they have not been covered or being able to be seen in the ER. So, but I don't believe, because we serve patients other than Native American patients as well, so we haven't heard that IHS is covering all of them. So right now they're getting covered either at the county level, or they have emergency medical that covers for them, or one of the alternative programs that the county has.
Thank you for that response. It's very helpful. I'd like to note a correction for Dr. Balakrishnan. In one of our slides, that doctor was listed, the title was listed as Chief Marketing Officer, and in fact, CMO is an acronym for Chief Medical Officer. So we regret any confusion that may have caused. We're still available for more questions.
Sure.
Thank you for making that correction, Mark. I appreciate it. This is Sonya. If there are other questions.
I was curious about one you mentioned that I don't know if you covered in the presentation about immigration status. Has that become a barrier, in your opinion, for people who come in and testing, or how is that impacting what you're seeing at your drive-through test site?
We have not turned away anybody because of insurance or immigration status, so I don't think at the clinic level it has been a barrier of any sort. We pretty much anybody who falls into the testing criteria or the providers have requested for testing, we have tested them. For anybody that doesn't have insurance, the agency is basically picking up the cost of the testing, and everything else is getting billed to their insurance.
Thank you.
We're not tracking patients' immigration status, but just in looking at the patients that are getting tested, I've definitely noticed a pretty high percentage of patients that are cash pay or on our sliding scale program. I'd say it's a higher percentage of cash pay / sliding scale patients that are being tested than we regularly see in the clinic.
Okay.
It's been interesting.
I was about to say, I've noticed that you're keeping track of risk factors as you are tracking your patients who come to the drive-thru. And if that information is going to be used for any further analysis once there's additional time, or how that information might help you in the future. Any plans on using the risk factor information you collect, that data?
Right now we're just collecting the risk factor data just so we can keep a close eye on the patients that do have those risk factors. I think this is just good data to have should we ever need it in the future, but I'm not anticipating needing it in the future, but you never know. So it's just good to have. But I do think that insurance type and those type of demographic data points may be interesting to start keeping track of too.
Okay. Okay. We're right at 5 after 2, and some of our audience is appears to have really had all their questions answered. I'm really pleased with your capacity to stay online and help us out. I know we went a little longer, and even though we had a crowded agenda, we got a great deal of information out with everyone. So I really appreciate everyone's help. If you, just as a reminder, if you're interested in downloading the slide set, it's available as a PDF download in the pods showing in the Adobe window. Also, web links for forms that were mentioned throughout some of the presentations are available as full downloads. Again, that's in the web links 2 pod. We'll leave that open for a little while. Again, I want to thank you for this really useful information. We had a great turnout today, and we're looking forward to continuing our conversations in this community of learning as we go on. Remember that 2 weeks from today, on April 17th, we'll have a second session of our community of learning on the COVID-19 response, and we'll look forward to welcoming you back to continue this really useful conversation. Thanks again, and we really appreciate the support of not only all of our audience with their insightful questions, but of course our presenters and who made this all possible. And just want to thank everyone.
Thank you.
Thank you. We'll leave the room open for a little while for those who want to do downloads, but once you've decided to leave, please exit the room. That can close out the discussion adequately for the Adobe Room use, and we look forward to seeing you in a couple of weeks. Goodbye now.
The leader has ended the meeting. Goodbye.